first speaker I want to introduce to you is the fabulous Paula. She's a certified psychotherapist and a mental health educator and the vice president of Mintaforte, which is a partner in this event. And Paula, I want to ask you first to tell us about what are some mental health experiences that women can go through in relation to their reproductive system. And would you say there are any taboos or stigmas around these experiences? And maybe you have experiences yourself that you want to share when it comes to this.
Thank you, Camilla. Hello, everyone. And first, thank you for this invitation. Across our lifespan, us women will find ourselves in a variety of challenging physical and psychological contexts, a series of which will happen mainly due to our reproductive system. And added to this, yes, will be all the cultural myths and expectations that will shape how we respond emotionally and how we cope. And if I go back to the very beginning of my close encounter with my reproductive system, that is when I first got my menstruation, I remember there was such a strong taboo around it that my mother would encourage me to cover it up so that my brother did not see my pads in the bin because he would not understand. And also, I remember that the way we would call that time of the month in our family was that you are sick, which confused me a lot because I was feeling okay and I knew I had no illness, and I didn't know why people in my family would say about me that I'm sick. So yeah, the arrival of menstruation signals the onset of our reproductive capacity, which has a deep psychological meaning, but can also be frightening and quite confusing if we are not guided properly in understanding it, as was my personal experience. Menstruation also brings along hormonal changes and various physical, psychological, and practical challenges each month for about half of our life. And that's about, if we think about it, 450 menstrual cycles, which will sometimes come with very uncomfortable and often painful physical symptoms and emotional states. Many women experience the well-known PMS, which is a strong emotional experience around the menstrual days, the menstruation days, which can be very heavy when experienced. But if we move forward to take a brief look at different points in our reproductive life and how they can be emotionally challenging, after puberty onset and with the start of our sexual life, whether it is during adolescence or later in our adult life, we are automatically faced with the possibility of pregnancy. This brings the need to decide on whether or not and when is the time to welcome children into our lives, which is actually not an easy choice, as we need to take into account so many aspects, like the presence and reliability of our partner, social network, how this will fit into our broader life picture, what will we give up, and so on. So then choosing not, for example, choosing not to conceive just yet brings us in the face of contraceptive options, none of which is actually cost-free. And I'm not talking of financial costs here. For example, one of the most popular oral contraceptives, that is the pill, which is only available to women, comes with great risk of physical and emotional side effects. And many women who choose oral contraceptives due to various reasons, they experience strong depressive symptoms. along with this. Then various life circumstances can lead to unplanned, often unwanted pregnancy, which significantly impacts a woman's emotional and social life, and it demands for a quick response. On one hand, there is the decision to terminate the pregnancy, which comes at a high biological, emotional, and social costs, because abortion is still a controversial and stigmatized procedure. And on the other hand, choosing to keep the baby can be equally terrifying and damaging, especially for teenage girls or single women who benefit from little to no support from their families and close relationships. So either way we go, it can bring us in the face of many difficult emotions, and it can put us at risk of different mood and anxiety disorders in more severe cases. The conception issue is, or question, is not one that we decide on once, like if to conceive or not. It's not something that we decide on and then forget about it, but it's one that needs constant updating, with the monthly reminder that we are biologically ready, the choice of using the contraceptive method every time we have sex with a partner, then the social and cultural pressure to procreate, and also the awareness that fertility decreases as we age. So it's not an easy decision, but one that we have to update and take actually every month as we move forward in our life. Then further on, and if and when we decide we want children, trying out can go in so many directions. Infertility issues may arise, as we've heard before. Alternative options like technologically induced conception or adoption, each comes with their own package of challenges, and there is at least some level of stigma attached to each option. So it's not always easy to get support or to talk about it. Then perinatal loss in different forms, like miscarriage that we've had examples of before, is quite frequent and has a tremendous physical and emotional impact, oftentimes being experienced as trauma. Even carrying a pregnancy to term does not come easy. Giving birth is a complex, sometimes heavy physical and psychological experience, which involves transitioning from previous known life to a whole new realm, which comes with new challenges and new meanings. And then motherhood can take us in so many directions, and the nuances of how different women experience this are so broad that really no single story can encompass it all. And finally, as we approach midlife, anticipation of menopause, the loss of fertility, and then the experience of menopause itself are extremely complex. And we have to integrate this transformation into a new sense of ourselves as women while dealing with overwhelming physical symptoms. So we moved through this quite fast, but the amount of time we have today is really not enough to make justice to each of these experiences. But as we can see, our lives are really on a continuous roller coaster with so many transformations and events and decisions that we have to make, all of which can bring joy and blessing, while also being quite demanding and often really terrifying in our lives as women.
I, for one, really appreciate this overview, and this kind of sets the stage for our discussion moving forward, because the experiences that women go through is not just going through a miscarriage or not just going through postpartum depression. It's such a wide variety of experiences that women have. And of course, not all negative, some are amazing experiences as well. And my question is, because many of these biological events that you describe are out of our control, because having this reproductive system is not something that we choose, what is maybe one thing that you see as important in mitigating the impact of our female biology, let's say, on our mental health?
I believe the most important mitigator is our societal capacity to provide a space for any experience to exist and support each woman to respond to it. Experiences with our reproductive system come in all shapes and colors, with many mixed and contradicting feelings, each of which is equally valid and needs to be cared for. Cultural myths and expectations strongly influence our attitudes towards different aspects of our biology and organize. Sometimes we can say it even limit our freedom to experience certain events as they are. As we've heard before, shame, isolation, helplessness are some of the most deleterious feelings, which often come as a result of societal stigma and rejection. So I would say events like this, for example, which bring us forward, because we really need to start talking about all these different experiences as they are something normal, part of human female existence, so that we as women can feel that our experience can fit in this world, can be shared, and it's not something to be ashamed of. It can be seen, and we can ask for support and receive support throughout our lifespan.
And let's hope we are pushing things in that direction by having events like this one. Thank you so much, Paula. I want to move to a doctor now, another type of doctor. Alexandra Poyner is an OBGYN, a certified specialist in the general management of endometriosis. She's actually the first ever specialist in endometriosis in Romania. I was wondering if you could just give us some more context about the situation for women's health in Romania, and in particular, maybe tell us some more about endometriosis.
Hi, thank you. Yes, that was exactly what I was planning to do. So I'm not the first specialist. I'm the first Romanian, because we are few, but we are, I don't know, I think 5 or 6. And I'm the first one to be certified officially by a university, the University of Bordeaux. So my presentation will have 2 parts. In the first part, I will highlight some landmarks in Romanian history, and then Romanian history, and then we will talk a bit about endometriosis, and there is where I will need your help. So I would like to start my presentation by reminding you of one of the first Romanian activists, women's rights activists. She was the first Romanian gynecologist, Maria Cuțaridu Crătunescu. She founded the first daycare center in Romania, allowing women to work while their children were well taken care of. Women had a rough path in Romania. They only got the right to vote in 1929. They shortly lost that right when the Communist Party took over. And in that period, women lost a lot of rights. They had no contraceptive options, and the abortion was banned. So no Planned Parenthood. We couldn't discuss about Planned Parenthood. In the meantime, in 1960, the first contraceptive pill was approved in the USA, and 1 year later in Europe. So when women have no contraception options, they start to look for alternative solutions. So a lot of septic and illegal abortions took place, being conducted by non-medical personnel and in non-sterile conditions, and a lot of women got to lose their uterus and their lives. So in 1989, the communist era was over. Women got back all their rights. So 30-something years later, everything should be great, right? Because we have access to free medical care. And in Romania, the law says that pregnant women have free medical care, and they do have free medical care during the pregnancy and during the 42 days afterwards. And they have access to screening programs, to information, and all sorts of good things, right? But is it really that good? In 2019, Romania registered the lowest rate of breast cancer screening in Europe, only 9%. It's bigger than the one registered in 2017, who was 0.2%, but still very, very low. Also, Romania has the highest incidence of cervical cancer in the European Union. So who organized an analysis of the state of health in Romania, and they found we still have a lot of problems. Okay, so obviously our health system isn't great. We still aren't able to get full access to screening programs for women for oncological disease and serious diseases like breast cancer and cervical cancer. So in this context, is it allowed to come and speak of a new old disease? What about endometriosis? So I think that yes, we should speak about endometriosis, even though we still have a lot of other problems. Endometriosis is important and women should be aware of this. So endometriosis affects 1 in 10 women. So I say that a rate of 10% is quite high and important. So now I'm going to ask you some questions and please answer me, and we'll make kind of a group diagnosis. So do you have menstrual pains, first of all? And on a scale of 1 to 10, 1 being no pain and 10 being worst pain you ever felt in your life, what is the grade you would give your menstrual pains? If you're not helping me, this isn't great. So we have 2, 1, 3. Not bad. 8, 4, so 6. A normal menstruation lasts from 3 to 7 days. So out of these menstruation days, how many days do you have pains? Okay. Do you need to take more than 1 painkiller? So if you answer that you do have menstrual pains that last more than 2 days, that need more than 1 painkiller, and you have to take to analyze your body and to see if you have experienced other symptoms like bloating, diarrhea, constipation, lack of energy, you might have endometriosis. So what exactly is endometriosis? The uterus has an inner lining which is called endometrium. During each menstrual cycle, a lot of women experience a reflux through their fallopian tubes, and the menstrual blood goes out of the uterus in the abdominal cavity. Along with this blood, endometrial cells go out, and on some women, these endometrial cells get implanted at the level of the peritoneum, bladder, bowel, wherever they want. So these endometrial cells that get implanted ectopically react as the endometrial cells in your uterus. So when your endometrium bleeds in the uterus, it bleeds outside the uterus as well. And it's normal to bleed in the uterus, but not outside. So if you have bleeding in your abdomen, this leads to pain through inflammation. And this inflammation gets cured by a scar tissue. So this scar tissue grows every month with each menstrual cycle that passes by. And symptoms get worse every month. So, okay, you take painkillers, what's the deal? It's not that simple, because this scar tissue can, let's say this scar tissue is implanted at the level of your ovaries. it grows and it grows and it grows, and it replaces your normal ovarian tissue. So this is bad, because if you don't have normal ovarian tissue, you have a lack of, you have a decrease in your ovarian reserve, and this affects your fertility, and it also affects your quality of ovocytes. So what we know so far is that 50% of women with infertility suffer from endometriosis. This is extremely high. So 50% of women with infertility have endometriosis, and the rest of 50% are all the other causes. So this is a major health issue. Also, if this scar tissue or endometriotic tissue is located at the level of your intestine, it grows and it grows as each month passes by, and it can lead to an occlusion in your intestine, which can lead to a very big and not so pleasant surgery, and it leads to emergency surgery. So I have a lot of patients that tell me that they have had menstrual pains all of their lives, and they went to doctors, and they told them it's okay, you'll have a baby and it will go away. No, it will not. And you need to know, and what I want to leave you with is that it's not normal to have menstrual pains. It's not normal to miss out work or to miss out school because you have menstrual pains. It's not normal to stay every month at home in your bed and cry because you are in pain. So each woman that experiences these pains needs to have a medical exam at a doctor who is specialized in endometriosis. Okay, it's not always endometriosis, but the chances are high. You have a 10% chance that there is endometriosis, and you need to exclude that as a cause. Second of all, endometriosis is a disease that it's a chronic disease, so you'll have it all of your life. You need to accept it if you do. But you need to be aware that there are ways to keep it under control. So this disease is related to your menstrual cycle. So if we stop your menstrual cycle, we stop this disease. And I know and I notice, and this is a big frustration of mine, that in Romania we have a great stigma associated with contraceptive pills. But they can save lives. They are the pill that changed the world, and we need to acknowledge this. There is not one great pill for everybody. So we need to see which pill is the best option for you. But please do not start out by having this preconception regarding the contraceptive pill. Also, if this disease is diagnosed early on, we can manage it without any problems, and we can salvage a great month of the fertility of the patient. If not, we can still have options. This disease can be operated, but it's major surgery. It's difficult for the patient and for the doctor. So this is why it's very important to catch it early on. What I want to leave you with is that it is not normal to have menstrual pains. And if you and your friends have menstrual pains, please analyze it and go see a doctor today. Thank you.
Thank you so much, Alexandra. Really appreciate you talking about this very important topic, and I'm sure you'll get more questions as we go on. It's incredible that it can be revolutionary to say that having intense menstrual pain is not normal. So I appreciate you shedding some light on this.
Thank you.
Thank you, Alexandra. We are going to move on to another part of Europe right now. We are going to move to my home country of Norway, where we have a psychologist who is also author of several books and scientific articles and publications. And she's also an esteemed lecturer and speaker. And Kari, welcome. We're looking forward to listening to you. Kari is gonna take us to a little bit of a different perspective on women's health, and it's regarding specifically women's mental health. And the question that we would like to ask you now to begin with is, how can we help women who have serious drug or mental health related issues in the best way possible? And is the help that is already being offered good enough?
Well, in 6 minutes and 30 seconds, it's impossible to answer that question. But the last question I can ask you, definitely no. We are not giving the best and the most safe treatment for women with addiction problem. When I was listening to the presentation earlier, I was thinking all the time how important it is to share things together, to talk about personal stories, to listen to others, because then you realize that you're not alone. And there are somebody else that are like you, and then the shame will go down. The women I'm talking about, they have all get babies, but they have also lost them in that sense that after a while, when their drug and addiction problem became so serious that the healthcare system, the welfare system said, no, you are not allowed anymore to have these babies or your children. And then is the big issue, how could we help them in the best way? And what we also be talking about today is the shame of being not taken care of, that the authorities, the healthcare system should have seen you in a different way. And I think that is very important when we're talking about women's psychological problem and also people with double diagnosis, both addiction and psychological problem, because there is, in Norway at least, there's nothing more shameful than being a woman with an addiction problem. You can be whatever. As a man, you can be it, it's okay. But if you're a woman, then you are a disaster. So not being seen, I think that is more important than having all the technical things, all the, how to say, right techniques of treating people. It's much more the attitudes we have, and at least how to speak, that we are not have this moralistic view as we have in Norway, because then you will have this silence as this conference is breaking down, that we can talk about things that are difficult to talk about. Because in Norway, women with addiction problems, they are really invisible. You don't see them. And we know for a lot of research is that the reason why women develop different kind of addiction problem is not because they find it funny to have an addiction problem or said to themselves that this is something that is okay for me. They did it because they had a trauma behind this. And what we know from a lot of research in Norway and also international study is that women that has been exposed to violence and sexual abuse are much more likely to develop serious addiction problem later in life. And when we have that view and we also have the knowledge about this, then we have a huge, how to speak, a challenge in not only Norway, but in the rest of the world. How do we meet these women in the best way when they seek help? All data, and this data has been rather stable for many years, we can see that if you go to an addiction treatment center in Norway or other places in the world, you will find about 70% men and 30% women. That means that the women are always in the minority. They are the smallest part in this treatment center. And what we also know is that when women come to this treatment center, they will get a treatment that are tailored by men. Research in the psychiatric field has a lot of, the data is a lot on women, that there are women that have been asked for different kind of treatment or problem. In the addiction field, it is the man that has been, it's been made research on man, and they have seen what is the best treatment for you, how is your problem, and all the knowledge, most of the knowledge we have in the addiction treatment center is research on man. So that means that when you come into a treatment center, you have maybe sexual abuse in your childhood, a lot of violence in your grown-up life, you have lost your children, and then you have all this trauma going into a treatment center that doesn't take care of this kind of position at all. So they don't see it. They only see a diagnosis, they see an addiction problem, but they don't see all the things behind this kind of complex thing. And what these women get is a treatment as if they were men. And that means that a lot of these women aren't give any response to the treatment, a lot of different kind of problem they have, and they leave maybe also treatment before they should do it. There's very little research about what is good for women. We have very few RCT studies, but the few we have, if you compare male gender specific treatment with gender mixed treatment, every study says that having gender specific treatment are best for women. So that we know, and we know it also for clinical point of view. Being a woman sitting in a group therapy, you would never talk about your abuse, your rape, your failure of being a mother together with other men. So you wouldn't do that at all. So that means that we know the research side, this is better for women to be taken care of in specific treatment center. And we know that nobody of us would expose ourselves to this problem at all. So that means that what we do in the treatment is that we re-traumatize this woman. And what we do is that we say to this woman that we actually don't care about your history. We only look about your diagnosis. And that is a problem in the medical way of treating women today, is about that we don't see that we don't see the women specific issues. We only see a diagnosis like having an addiction problem. And as long as we do that, we will always have a challenging about helping these women, and we'll also have huge problem making them be able and would like to go into treatment also. So we need much more. We need much more treatment, not much more research. We need much more better clinical example of how to take care of these women. And if we don't get that, then we will have huge problem. So that is my main issue today, is talk about it, make treatment as good as women would like to go into treatment. Then you have to make it gender specific, and we need much more research on it. Thank you.
Thank you so much, Kari. I actually want to ask you a follow-up question before we move to Kate, because this is such a, obviously there's so much to say about this that cannot be covered in the 5-6 minutes that we have given you at this time. And there might be more questions from the participants as well. But I first want to ask you, is there something that you could point out that we need in order to improve the help that we offer to these women?
We need, I think the first thing we had to do is to look at the treatment center we have. And then I think we had, and that sounds maybe very old fashioned, but I think we had to split. And we need to have treatment center only for women. We have seen that in Norway. When we did that in Norway, the women stayed longer in treatment. The satisfaction of treatment was much, much higher, and they had better results. This is a little more expensive to do it, because then you need much more staff to treat both men and women. But I think that is the first most important thing to do, to split it and to make women make their own treatment. And you can see if you have only women in groups, they are different than men. They are talking in a different way. They are much more relational orientated. The shame is different. Men are normally shameful because they have lost a job. My women, they are shameful because they lost their children. So they have other point of view to look at also. So that is one thing, having treatment center for women. And then we had to do much more research on it. It should be said that if you're going to have money from the state or doing research, then you have to take in account the gender specific differences. What is difference? We have seen it today. And what we see today also is this, that is invisible. We don't talk about it anymore. We did it in the 80s, 90s. We were talking about it. Today it's gone. And we can see the suffering in losing a child, miscarriage, and also addiction problems. It's the same. And the more I think we get together and talk about our way of behaving, our way of understanding what is the problem, then we also can tailor treatment in a different way. So split it. That is my, and have group therapeutic group center, have only women in the group. Don't mix it with man. It just make the man taking the position, and the women are good listeners when you have them in together with men. So yeah, that is a beginning.
Thank you so much, Kari. It's really enlightening to listen to you. And I do hope that we'll make some improvements in how we treat women who have these kinds of problems and who struggle with these things as well.
Yeah, I just want to say that even though Norway is one of the most equal country of equality, we have a long, long way to go in these items.
So a lot of potential. Kate, I know these gender-related challenges is not something that you're unfamiliar with. It's something you know very well. So Kate D, Catherine Lourdes D, is a Polylogos mentor as well. She has a double PhD in human rights and migration, and she's an academic practitioner specializing in security, migration, European project management. But you're also the gender expert many times. And Kate, can you please come in and give us a little bit more from a sociological and human rights-based perspective about women's access to healthcare, and maybe what are some consequences of the current COVID-19 pandemic for women who are seeking healthcare?
Thank you, Camilla, and hello, everyone. So just a little bit of introduction on my background. So my background is really indeed focused on gender and migration and the intersectionality of those two. So since 2011, I've been specializing in sexual and reproductive health and rights. And since around 2017, with a specific focus group that is of migrant women and particularly vulnerable groups, including, for example, women with disabilities, but also national minorities in Eastern Europe, such as Roma women. So we've done both academic research as well as advocacy pretty much across Europe throughout these years, starting all the way from Spain through Belgium, France, Italy, Germany, Romania, and Bulgaria. But I have a particular affinity to the countries that I've actually lived in, because then I have a kind of tripartite relationship as researcher, as advocate for women, and also as a woman and a migrant myself. So these are maybe the countries that I'll focus on a little bit more in the 5 minutes that I have today. So as we know, and as repeated during this session, there are so many challenges faced by women in terms of access to healthcare. So this can be from not being believed when we say that we have pain, or saying that it's just normal to have pain because you are a woman, or to having medical issues and procedures trivialized, or just not having access to healthcare at all, which is an even bigger problem. But one of the most important ones, I think, is also to not have control over our own bodies. We were speaking about contraception earlier, and one of the great things across the whole of Europe is that when it comes to issues of contraception or fertility, especially for married women or for young women, often we don't have control over our own bodies. We need to ask permission from either our husbands or, in the case, maybe our fathers. And this is also the same across the world. Now, vulnerable women, migrant women in particular, but also minorities and those in unstable situations, have an even harder time. Think of all of the challenges that we as women face and compound all of the other vulnerabilities to that. And even this applies even to accessing the very basics of healthcare. So pre-COVID, this was already a major issue. So it was actually highlighted in the European Pact for Migration and Asylum in 2001. One of the key pillars there is women's health, in particular, women's sexual and reproductive health. Now, for that to be highlighted as a pillar amongst the many, many issues that we might have with regard to migration and asylum, I cannot even name all of them, shows you that, yes, this is a critical issue. It is being heard across the board and also by European policymakers. So it is something that we do need to talk about. So what I want to discuss today are the 3 barriers to access to healthcare by particularly vulnerable women. what COVID has done to this, because this is a timely reminder of where we are 2 years into the pandemic, and hopefully end on a positive note. Let's see if we have time for that. So there are three main barriers that we've identified when it comes to access to healthcare by women. It's information, institutions, and norms. So I'll start briefly with information. This is the primary barrier, knowing what is there and how to access it. So you can imagine that when you're a migrant, you are in a whole new environment. So this is different from, for example, citizens who were born in that country or those who migrated early on, who, for example, you might already have a family doctor, you already know where's the emergency room, you know which is the best pharmacy to buy the cheap drugs. As a migrant, when you come into a new country, you know nothing about this, not even how to access the very basic thing of seeing a family doctor, for example. So maybe in this imaginary country, there is an established structure of how to access healthcare. Maybe there's already a multi-step plan since decades established, and all we need to know is know about it. How will we know? You know, there's this missing step there. How will they know? A lot of information is out there, thanks to the internet and a lot of welcome brochures. But how will migrants know where to get this specific brochure that tells you specifically how to access healthcare in the country that you're in, or how to find that information? But actually, what is in reality is that there is not always an established structure, and things change yearly, if not more often. You might need to go to this office in 2010, but in 2011, you need to go to that office first. And now with the pandemic, you need to do everything online through this specific email address. There's a lot of information that isn't necessarily translated to the people who need it the most. And this is even worse for those particularly vulnerable. I refer here to irregular migrants, because whereas regular migrants, for example, can take the time to access this information, they can make it known to public authorities that they are here and that they need it. Irregular migrants have the additional challenge of fear of deportation. So you need to then balance your healthcare needs with your economic needs and your fears. I've experienced this now more than 6 times moving across Europe. It's very difficult. There are language issues, the information issues, also the cultural norm issues that you see in each country. It should theoretically have been easier for me as a skilled worker migrant, let's say, having all of the benefits behind that, but it has not been. The second barrier that I wanted to discuss today is the institutional barrier. So imagine that you as a migrant already have all the information. You have all the documents that you need to show the country that you have access to their medical care. Sometimes the barrier is their structural. So each country has different documentary requirements. For example, passports are quite different depending on which country you come from. Not speaking about the power of the passport, but speaking of the actual physical paper. Some passports are biometric, some are not. Some countries do not accept you to register in their system without the biometric passport. There's no solution for that at the moment. You're just not registered in the system. Sometimes there are documents that are required. For example, your birth certificate, marriage certificate, sometimes things need to be apostilled. So it's not really an immediate thing that once you have all the information, you know where to go, that you will get the care that you need. So I'll give you an example of my experience in Romania. Actually, it took me 5 months since arriving to get medical coverage. This included 6 doctors, 3 private hospitals, and 1 3-day confinement stay at a public hospital. The only reason I got medical coverage, which I was legally entitled to since I landed, was because of workarounds and help from friends. And this was a very specific situation, and it was clear that the institution itself was unprepared for migrants or people who were, let's say, under a different heading than citizens or other EU citizens. Because we later on discovered that my 2-year-old, who was registered with me for medical coverage, was registered as an independent worker. They could not register him as a child because he was neither a Romanian child nor a European child, purely European child. So therefore, he is a 2-year-old independent worker in Cluj. This is fantastic. I hope that doesn't impact him in the future. So it's really incredulous, but this is one of the better scenarios because we actually got health coverage. Since 2018, actually, we've been hearing stories of women who repeatedly visited public offices only to be sent from one door to another, like go from this office to that office, and that second office tells you actually, no, you need to go to another building only on Tuesdays, only at 9 a.m. This is an actual story. In late 2018, we were working in another city, and we heard the story of one woman who could not get her pregnancy documented. So in Romania, you are covered. Your health care is covered if you are pregnant, no matter what your status is. So this is one of the fantastic situations. Whether you are illegal or whatever your nationality is, it is covered. The problem is that you need to document that you are pregnant. So this particular woman, she could not get her pregnancy documented. So when she needed health care related to the pregnancy, she was not in the system, and so she had to pay for that health care. So can you imagine, you're pregnant, you're obviously pregnant, you need this paper from a family doctor that says that you are pregnant to report to the insurance office that you are pregnant and should be covered by insurance. But you cannot get a family doctor because you're not covered by insurance. So what happens is that she spent her entire pregnancy fighting this, and then she was no longer pregnant and now is no longer covered by insurance. So there are certain frustrating institutional situations that are faced by, vulnerable groups, especially women, because we face particular health challenges as with regards to reproduction, as we heard earlier as well. So the third challenge that we have to accessing healthcare are social norms. One of the things that I've been hearing a lot over social media now is the Superwoman Syndrome. So it might sound familiar to many of us. It's when the woman is expected to advance in her career like she has no children, but raise her children like she has no work. So to never be late at the office, always attend those 5 p.m. meetings, even though you need to run to the gradinista. But raise your children properly. They need to eat 5 to 7 vegetables a day. You cannot keep on buying takeaway and so forth. You also need to take care of yourself. Don't gain too much weight. And also see your friends and have an active social life. It was coined in 1984 by Marjorie Shavitz, but it was actually seen long before 1984, and it's present now long after. Now, this has a strong effect on women's healthcare and our access to it, because what happens is that many women, because of these norms, neglect our own health for the sake of the family's health. So everyone will be able to see the doctor except you. We downplay our aches and pains as normal, which is what we're told anyway. We refrain from getting medical care. There's just no time between everything that we have to do. And then there's also a range of societal norms. So women are at a greater risk for depression and anxiety. This has already been researched. But there's been little response from our health system in answer to this. And worse, there is a lot of judgment for not being enough. This judgment is compounded if you happen to be a woman, a mother, because then you are not only not enough as a woman, but you are not enough as a mother, which is possibly the worst thing that you can possibly say to anybody with a child. Now, access is also an issue under these traditional norms. So we have the issues of public transportation, the way cities are designed, and the way hospitals and clinics are designed as well. So an example of this is, as a mother with more than one small child, it will be very difficult for you to get onto public transportation, to get to a hospital or an emergency room or to the clinic that you need to go to. Locations are also not always thought about in the most smart of ways. There's a wonderful article about how cities are designed for men. Carrie actually reminded me of that when she was talking about how treatment programs are designed for men. So I do recommend reading that article. It's fantastic. An example of how sometimes really infrastructure isn't thought about is a free clinic in Brussels that we go to. It's a free clinic for mothers and children, and it's on the second floor of an old building behind three fire doors. So I have carried more strollers up these stairs than I can name in the 5 years that we've been in Brussels. Because how else are you supposed to access your healthcare but up those stairs and behind those three doors? And so women are helping other women. Just, this is the reality of it now. We need to deal with it. So these are the three things that have been major issues since before COVID. Now, since COVID, things have changed a lot. One of the major things is that we've found digital solutions. And digital solutions have been lauded by policymakers as being the great equalizer. Nobody needs to commute anymore. If you're working, you can take a quick 30-minute break to see your doctor. This is fantastic. The problem here is that it has not been designed for the vulnerable in our society. So this has a new set of problems because online solutions require an online identity. So in Norway, Belgium, and many other EU countries, there is a general identification system, usually tied to your bank, because this is the most secure system. So in order to access your healthcare platform, you need to have a bank account. In order to have a bank account, you need to have housing and usually income. In order to have housing and income, you need to be staying legally in the country under some kind of visa scheme. So imagine simply having no access because you don't have the basic form of this. Or maybe you tick all the boxes, you have everything, but then it takes, at the moment in Norway, it will take around 18 to 26 weeks without healthcare to get this as a migrant woman. So these are particularly difficult challenges. But remember that COVID doesn't have an impact on the illness of women and on our reproductive system. So pregnancy doesn't wait for when we're being covered by the healthcare system. Giving birth doesn't know whether or not you have that European health insurance card. Unexpected pregnancies, anxiety, depression, polycystic ovary syndrome, endometriosis, fibroids, none of these care whether or not you have access to the system. And they're all happening since before COVID and now during COVID with so many additional barriers to access by women. So even mobility is restricted now by the COVID Safe app, which is a great idea until you realize that it's also connected to an online verified identity, which is not something that those in a vulnerable situation have, not by choice, they simply do not have it. So now what we're doing is we're restricting the mobility of, for example, migrant women who happen to be irregular, or single mothers who are unregistered, and their access to healthcare as well. So this is something that needs to be thought about a bit more. So, sorry, now I have a itch in my throat. So what I wanted to end with is a good point. Actually, before that, I'll end with a little anecdote from 2020. It was just last year. So we were doing research on the impact of COVID on Eastern Europe. So we focused on Romania and Bulgaria in particular, and also Hungary. And as my focus is on women, we were looking at women in particular. So a female restaurant and hotel industry worker in Romania, she faced a forced resignation. That's when their employer forced her to sign a document saying that she resigned in Romanian, even though she did not speak Romanian. This is a different issue. We'll talk about this another day. So she signed this document, so she resigned from her work. And that means that she had no employment and the borders were closed. This was in March 2020. So she could not leave Romania. So her concern was medical coverage because she was living with her partner and there could be pregnancy at any time. So she called, the health insurance office multiple times and was hung up when she spoke in English, unfortunately. And she emailed them, but there was no response. I forgot about this until earlier this year when I emailed the health insurance agency myself. So in a few moments, there might be a baby entering this Zoom meeting because I gave birth just a few months ago to twin boys. I'm still breastfeeding them, so at some point they will want my breast. But what I wanted to say was I emailed the health insurance office because while I was pregnant, I was covered by the insurance system. I know this. And for the first, I believe, 30 days afterwards, correct me if I'm wrong, but it's been more than 30 days since then. And I wanted to know, how do I get my health insurance covered again? So I sent this email to them. I'm a migrant. This is my CNP. This is what I need. Thank you very much. After 10 days, they replied to me by email, and I was so pleasantly surprised. I opened the attachment, and it said, "We can only answer questions in Romanian. Please ask again." So that means somebody read my email. They knew the answer, or maybe knew somebody who knew the answer to my question. They wrote down their response. They printed it. They signed it, and they stamped it. They scanned it, and they sent it back to me. So I couldn't say anything. I was just wondering the amount of effort it took to do this. You could have just answered my question. And I'm not the only one writing to them in a language that's not Romanian. I'm pretty sure that most foreigners in Romania would be writing in the language that they are comfortable in, probably English. So there are many challenges that women face, especially migrant women, also vulnerable women. But there are mitigating factors, and these are women helping women. So from the support groups where we share our own experiences to informal networks like on Viber, WhatsApp, or Facebook, where if you need information and you can't find it, you just ask and somebody will answer you with their experience. It might not be the correct answer, but it will give you some kind of direction of where to go. You know, it can be literal helping hands if you need to bring a stroller up 2 flights of narrow stairs to get to a doctor's appointment. It can be emotional support online, you know, sharing experiences that we're not alone when we face this particular challenge, mental or physical, whatever it may be, or people who go out of their way to help with anything that you might need.
Thank you so much, Kate. It's good to hear some of these examples from real life as well, and some perspectives that we don't necessarily think about so much, especially if we are the natives or we are the majority. We don't know necessarily what is going on for those who are not as fortunate or who belong to other groups in society. So I really appreciate you pointing this out, Kate, and bringing this conversation to the more social aspects where women support women, and hopefully men will also support women if we are loud enough.